This nurse could not manage her time. She could not prioritize patients. Her meds were always late. Even though the charge nurse would cherry pick her assignment, she was still overwhelmed. And guess what? They cherry picked her assignment with the easiest patients, and she still could not keep up. Then an experienced nurse went up to her. So the nurse that I'm talking about, she had been a nurse for about 2 years. And the experienced nurse went up to her and said, listen, honey, you need to go to hospice. You're just not cutting it here. So in my mind, I always thought that, okay, so if you're not a good nurse, you go to hospice. 12 years later, because I saw that when I was a new grad in orientation. 12 years later, as an experienced nurse, that's not true. I know sometimes that dialysis nurses and hospice nurses get a bad rap. Like when I was in residency as a new grad, I was told that it was the nurses that got in trouble with the narcotics, because apparently dialysis nurses did not have access to the Pyxis or the Omnicell or whatever the medication management system in the hospital was. So if a nurse had gotten in trouble back in the day, I don't know about now, but back in the day, I heard that they used to send them to dialysis. And if you just weren't a good nurse with like assessment and patient care in the hospital, they would kind of gently nudge you to hospice. 12 years later, as an experienced nurse, I do not believe that. I do believe that great nurses go where their skill sets will prevail. So you're a new nurse in hospice, and I have plenty of tips and tricks to share with you, because I've been doing hospice. This is my 2nd year doing hospice, and I absolutely love it. Like, I always get asked, like, Donnakay, you're such a great nurse. Why don't you go back to school? Well, I didn't find anything that was worth going back to school for. I'm not about to put myself in thousands and thousands of dollars of debt or work excessive overtime to pay for school if I don't want to go in debt for something that I'm going to dread waking up and going to work every day. It is what it is. But for hospice and like palliative and like geriatrics, my heart is there. It really is. So I'm going to start this maybe 3 to 4 part series on an introduction, right? Like when I was going to hospice, like thank God I had a really good preceptor. Shout out to Courtney. She trained me well. And, with the skill sets that I have from all the other specialties that I've done, I think I just integrated and I flourished there. Now, granted, I'm no longer an RN case manager. I now do admissions, but I love my RN case managers, and as an admission nurse, I do function in a lot of the roles that the RN case manager does, because I set up that care plan and I lay the foundation. Like, I think of the patient's care as a house, and I lay the foundation and the structure, okay? I like to set my RN case managers up for success. So yes, I would love to just help you kind of navigate into this wonderful world of hospice. Duchess, when you're stepping into hospice, you're not just taking care of people, you're actually a guide, helping people through the most difficult, vulnerable, and sacred seasons of their lives. Not only are you guiding that patient, you're also guiding their family. Hospice is very family oriented. You are going to find that you're doing a lot of education, right? A huge part of what we do is teaching. Families are sacred, overwhelmed, and afraid. And sometimes initially it may seem that some families are standoffish or they're particular about the quality of care that you are giving. And it's not that you're not good at what you're doing, it's just that they are afraid and they don't trust you yet. So with RN case management, because it's a journey, and every single time that you do what you say that you're going to do, when they find that you are dependable and when they find that you have the knowledge to help guide them, you will find that that hard shell that they have tends to dissipate, and now they are going to reach out to you for everything. One of the reasons why I left RN case management was because I did my job so well that families called me all the time, even though I told them that we had a 24-hour on call and we had a triage nurse, they would always call me first. And truth be told, that's one of the signs of a really good nurse. When your families are like, listen, I get that there's someone else, and if you're not available, yes, I'll take someone else, but I really rely on you for knowledge. And I want to help you become like that. I want your families that as soon as you show up, as soon as they get your phone call, a text message from you, they automatically feel relief. They feel like, okay, I have someone in my corner fighting for me and advocating for me. And I'm going to help you with the education piece. I have so many tools that I want to share with you. For instance, this is an admission booklet that helps with knowing what to chart and knowing what to look for. Because a lot of times you have to really paint the picture in your notes and in your assessment, showing that this patient needs this care. Because if you are unable to do that, the hospice that you're working for will not get paid. And they need to get paid for the work that they do, because hospice is really expensive. The supplies that we provide, paying the nurses, paying the chaplain, paying the social worker, paying the CNA, paying for the medications, paying for the DME, all of these things cost money. And truth be told, we are giving care to people who need it, but we just have to be able to paint that picture accurately, okay? So for instance, say that you have a patient that has COPD. We're just gonna go through this real quickly, right? You're gonna look for some things, right? So this patient has severe chronic disease, right? One, is it disabling dyspnea at rest, right? Dyspnea, difficulty breathing at rest. So can your patient have a conversation like the way I'm having a conversation with you and not stop to catch their breath? I was a Vietnam veteran and it was a while. You want to look for these things, right? You want to look for poor response to bronchodilators, right? So after they take their inhalers, are they still having difficulty breathing, or does it only last for a few minutes? You want to chart these things. In my next video, I'll read a note for you that I've written on a COPD patient or on a CHF patient so that I can really paint the picture, right? Also, you want to look for progression of the disease, okay? So, evidence by recent or increased visits to the doctor, right? Or multiple recent hospitalizations for pulmonary infections and respiratory infections, right? Because it's in the presence of the COPD that these infections are happening, right? Because the average person is not just having multiple infections 2-3 times a year. I'm telling you, patients get it towards the end, you're going to see the frequency of infections happen, right? So a lot of times when my patients have back-to-back UTIs, every single time they have a UTI, I am educating family, okay? It's not natural for you to consistently have UTIs like that. Oh my God, did I come on here with no lippy? No, not on Jesus's internet. Am I on here with no lippy? Hold on, Duchess, hold on. I can't go out like that. I'm so sorry, friend. I should have done this before I started the video. But you want to factor in these things, right? In addition to that, you want to look at, are they having increased need for their oxygen? Now, in the hospital, with COPDers, we don't want to turn up their oxygen too high because, they retain CO2. But in hospice, everything is about comfort and dignity, right? So no, I'm not going to bump up their oxygen to 8, but if after they get up and walk to the bathroom and they're short of breath, you can temporarily bump up their oxygen, and then once they've catch their breath, you can lower it back to that 2 to 3 or 4 liter. Also, Duchess, one of the main things that we do as hospice nurses is that we provide emotional support and spiritual support. Do you know how many times families have asked me to pray with them? Do you know how many times I've had families yell at me and then immediately apologize? And that's another thing too, Duchess. In hospice, you have to learn not to take things personally, because it's not about you. It's about that dying loved one. And probably their relationship was really strained, and now you're walking in and you're watching people process grief in real time. Okay, I'm gonna have to make another video, Duchess, but know that this is gonna be a series helping nurses become hospice nurses. Also, Duchess, outside of me, you can go to the Medicare website. There, they have the LCD guidelines listed for every single diagnosis, primary diagnosis, and it tells you what they're looking for. In addition to that, every single hospice should provide some type of admission booklet, resource, training. So if your hospice isn't doing that, you should reach out to your DCS or your clinical manager and say, hey, I'm new, I need to be trained, I need to be oriented. Now, a lot of hospices are guilty for having poor orientation process. So really advocate for yourself, right? Yeah, so there's plenty of resources out there, and use the internet, friend. Like, it's there. But I'll also like to be a resource for I'd love to be a resource for you and all the nurses who are transitioning into hospice. I don't know everything, but what I do know, I'll gladly share. Gladly share.